Cataract surgery following penetrating keratoplasty poses unique challenges and certain modifications from a routine cataract surgery. This will make sure of a good survival of the graft post-cataract surgery. Intraoperatively, one should anticipate a poor corneal visibility and dry eye, which are more pronounced following corneal surgery. A low endothelial cell count, which warrants measures to prevent further cell loss. Peripheral anterior synechia, which might result in reduced anterior chamber working space. Fish mouthing of the graft host junction, and finally, a pre-existing corneal thinning. In this video, we would like to show a 13-year-old girl who underwent left eye cataract surgery in the year 2020, 4 years post-penetrating keratoplasty for a perforated corneal ulcer. A superior sclerocorneal tunnel is made using crescent blade and keratome. Care should be taken to avoid the graft host junction to prevent endothelial detachment. The chamber is inflated with viscoelastics. Generous use of dispersive viscoelastics is recommended to protect the corneal endothelium. Posterior synechia is released using a spatula. A continuous curvilinear capsulorhexis is initiated using a cystitome and completed using rhexis forceps. A good hydrodissection is done and the Cataractous lens is aspirated using Simcoe's irrigation aspiration cannula as much as possible. Coaxial irrigation and aspiration is done using a Phaco probe with low flow rate to remove the left out Cataractous lens. The bag is filled with viscoelastics and a 3-piece foldable intraocular lens is placed inside the bag. A superior peripheral iridectomy is done. The risk of posterior capsular opacification is high in a case of pediatric cataract surgery, and hence a primary posterior capsulorhexis is always advisable. Primary posterior capsulorhexis is done with rhexis forceps and the intraocular lens is restabilized. Excess viscoelastic substance is washed and the tunnel is closed with 2 interrupted 10-0 nylon sutures. The graft host junction is intact at the end of the surgery and there is no wound leak. This is to be ensured to avoid the risk of endophthalmitis. This is the 2-week postoperative follow-up picture of the child. A clear donor cornea is seen and a best corrected visual acuity of 6/24 was attained. The child had 1 episode of graft rejection which was successfully treated. The most recent follow-up 2 years post-operatively in September 2022, she maintained a best corrected visual acuity of 6/18. Thus, cataract surgery in a pediatric eye can be safely performed post-penetrating keratoplasty by making sure of the following points. Good corneal visibility intraoperatively by repeated use of balanced salt solution or viscoelastics over the cornea. avoiding graft host junction for the main port incision. Generous use of dispersive viscoelastics or a soft shell technique to protect the corneal endothelium. Avoiding Phaco energy in case of soft cataracts or using a low Phaco energy and flow rates wherever possible. Phaco probe should be meticulously oriented away from the corneal endothelium. Primary posterior capsulorhexis is advisable in any pediatric cataract surgery as the chance of inflammation and opacification is high. Making sure of the integrity of graft host junction at the end of the surgery, and finally restricting to a single port in these cases where paracentesis might increase the chance of losing graft host junction integrity. Thank you.